Kia ora, ladies and gentlemen. Good morning. I'm really pleased to be here. As David said, it's first time in Auckland. But more importantly, I think what the nurses, doctors, intensivists, cardiologists do, so the surgeons, the radiologists, everyone involved, is tough, and we struggle sometimes. But when I see patients, I think what you do is truly heroic. Recovering from a dissection, believe it or not, is harder than anything I've ever done, or I believe any of the other medics in this room have done. So it's incredible to see so many of you here. So I'm going to be talking about, can we actually predict these events before they happen? Because surely that makes sense. We should be trying to do that so we don't have to do emergency surgery. So we're going to talk about what is an aortic event. We're going to say why is it important to predict them, what factors actually predict them, and some of the ones we're kind of researching for the future. I know this has been discussed in quite a bit of detail before by Chris. Just briefly, the aorta's got 3 layers: the intima, which is very thin; the media, the middle part, which is made of collagen and elastin, it's very elastic; and then this adventitia on the outside, which gives it some strength. And although this word aortic dissection has been used a lot, the more accurate medical term is acute aortic syndrome, and it refers to 3 distinct conditions. First of all, aortic dissection, which you've all been told about. You have a little tear here in the intima, blood goes in between the layers, and that's really quite life-threatening. And then the other important one is an intramural hematoma, and this is where a blood vessel in the aortic wall can sometimes start bleeding, and a small proportion of those just get better by themselves, but actually some can progress into an aortic dissection like that. Now, for this graph, I want you to just think of a spring, actually, and on this axis is stress, which is essentially how much force is being applied to the spring. And then on this side is strain, which is how much is that spring lengthening. So if you imagine you pulling on a spring, it stretches, doesn't it? And then if you let go, it'll go back, and that's because it's elastic. The aorta is exactly the same. So as the heart beats, it expands, and then it comes back. But if you expand it too much, it stops becoming elastic, and at this point, which is called the yield strength, it can never really be elastic again. And if you push it a bit further, it will actually fracture. It's just the same. So from a very simplistic point of view, if you imagine an aorta and there's blood in the middle, aortic dissection or rupture can occur when the force on the aortic wall due to blood flow exceeds its strength. Now, while I've said that, the reality is, whatever any of us say, the actual mechanism is very, very poorly understood, how these dissections happen. And this graph is just an example. You can have healthy intima, and just due to a little nick, blood can enter, and if that goes in a straight line, it can then pass in between the layers and cause a dissection. It is quite directional, so if you have a cut in the intima in a kind of 45-degree angle, then it will spread in a different way. But it's important to understand we know very little, and some of the research I do is to understand this more. So I just want to go through 2 case studies very briefly. This is a patient who had an aortic dissection. He was a man in his 50s. Typically we see this happen in the middle of the night. This was at 2:30 a.m. He had 3 hours of chest pain, but he was previously completely well, on no medication. In the ambulance they thought it was a heart attack, so they gave him some aspirin, some oxygen, some painkillers, and he was pretty unwell when he came into hospital, and a CT scan showed, I don't know if you can see this faint line, but that's the dissection flap in the aorta. And when he had his operation, the aorta was opened, and you can see this is a tear, the dissection flap, and he was operated on about 6 a.m., which was 4 or 5 hours after coming into hospital. He was confused, his kidneys had stopped working, and he had a big operation where they replaced most of his root and ascending aorta. And after the operation, he was on the intensive care unit for about a week. He was confused. his right arm was weak, he had a chest infection and needed a breathing tube to help him breathe. He was in hospital for 25 days and that hospital stay cost quite a bit. He, because of the extent of the dissection, he's going to need follow-up, but he did actually recover reasonably well in the end, despite that tough recovery. Now this second patient's very different. He's an artist who lives near London, and he was getting more short of breath, so his GP sent him in to us, and there was a murmur, and he had a scan, and what it showed was his aortic root was very big. It was like a balloon. The rest of the aorta was relatively normal, but it's 7 centimetres. So we decided, he agreed to have that changed. He was relatively young, so he asked for a mechanical valve, which hopefully will last his lifetime, but he will need to be on blood thinners. And he had it replaced with this tube graft. And he came in on a planned Monday. The operation time was 3 hours. He went home on the 5th post-operative day, no complications, and he took part in a research study that I was doing. And when I saw him at a year after surgery, he was doing very well. This is one of the scans he had before and after. It's a special computational flow study, and it shows before the operation, the flow was really quite abnormal in his aorta because it was big. And then after the operation, you can see that the green lines are kind of straight rather than haphazard here. The velocities or the speed is quite, not too fast like in this scan, and he's doing pretty well. It's not quite as natural as a normal aorta is. You can see this angulation isn't ideal, but it's probably as good as we can get. Just to really demonstrate, this is a worst case scenario. Most of you clearly have done very well and are not in this category, but if you do an elective or planned operation, the mortality is less, the survival is better. You can have a high quality, experienced team who do the operation, sorry, that's a mistake, but in daylight hours, low complications, and the cost to society is low. I've also mentioned this line here, chance of a biological solution, and what that means is there's more chance of you keeping your own tissue and not needing blood thinners. And this is another study we've done, and what it shows is mechanical valves are very good, they last a good period of time, but nothing is as good as a natural valve. And if you look at the flow of blood with a normal valve, you can see it's very symmetrical and smooth. But when you have a mechanical valve, it's slightly different, and we should ideally in all patients, where possible, try and offer a biological solution. So how can we predict these aortic events? I would say that there are 3 categories. I would say that aortic size definitely can help predict it. Genetic weaknesses, genetic aortic wall weaknesses, certain markers in the blood, small molecules, and certain clinical characteristics. In terms of probably, these 2 areas are ones that I research, and I really think in the future they'll help us predict aortic events, and also the shape of your aorta. And then in terms of maybe possibly activity and sleep levels, and there's some research into seasonal and atmospheric variations, but at the moment that evidence is pretty weak. So let's go through some of these. First of all, aortic size. Now, when you start getting around 4.5 centimetres above there, your risk does start increasing. And actually, when your ascending aorta is about 6 centimetres, 30% of those people probably would have already suffered, either had surgery or suffered an acute event. So it makes sense to replace the aorta in most people around 5 or 5.5 centimetres, just to get it before it happens. Genetic weaknesses. Now, these letters are confusing to everyone, including doctors and myself. What these letters are, they're just names of genes that have been found to be associated. So this is a long list of genes. And they've now suggested that for certain genes, you can treat patients just like all others. So at around 5.5 centimetres, if you have this gene, we would recommend you have your ascending aorta replaced. Now, there's a few rare genes here, very special ones, And what we actually do is we suggest the aorta is replaced at a smaller size. That's probably because the aorta is a bit more fragile in these patients. The reality is that in non-syndromic genetic aortopathies, we only know about 30% of the genes, so the rest are still to be discovered. Marfan syndrome is really, I think, what people know most about, and this was one of the early kind of case reports on Marfan syndrome, and they're particularly known to have problems with weak aortas and sometimes other parts of the bodies, including the eyes. And you would want to often keep a close eye on these kinds of patients, and especially in them, offer them an elective operation before anything bad happens. There are certain small molecules or markers in the blood, we call them biomarkers, and sometimes through a simple test, they may suggest that you have a predisposition to aortic disease. So this picture shows a group, some scientists who showed that certain molecules called RNAs, these red ones, which are different ones to the blue, were more common in patients with aneurysms. So they could differentiate between the normal patients in blue and the ones with aneurysm in red. And unfortunately, the problem is it's just not accurate enough. At the turn of the century, people thought this was going to change medicine and we could do simple blood tests. I would say that it's been really disappointing, and none of the blood tests can really predict accurately whether you're going to have an aneurysm or dissection. Certain clinical characteristics and studies have been associated with aneurysms. So older people, those with hypertension and high cholesterol, the aneurysm growth rate is interesting because you could have an aneurysm and it just doesn't grow at all. Maybe 1 or 0.5 millimeter a year, and for some reason other patients, they have a higher growth rate, and we would want to do something earlier for those kinds of patients. Previous cardiac surgery, a stiff aorta because it can fracture more easily, people with 2 leaflets on their aortic valve, brain aneurysms, family history, and certain other conditions such as renal cysts. So I want to show you a research study, a video from a research study we've been doing at Imperial. And here we use MRI and very powerful computers to simulate blood flow through the body. This is a 40-year-old cardiac surgeon. He's pretty healthy in London. He's pretty healthy. He plays cricket. He probably eats a bit too much curry, but otherwise he doesn't look too bad. And you can see the blood flow is really smooth. It's going in straight lines, and this velocity sign, none of it's going into the red. It's nice and smooth, and that's what we really want to get blood flow like. Now this video is a 55-year-old man. He's not very active. He stays at home most of the time. He's a Londoner. He's got an aneurysm, so he's got a big aorta there. He's also got a very tight aortic valve. It's not opening well. And I don't know if you can see, but the flow is faster, and it's coming out in at an odd angle. And we're trying to use these flow patterns to help predict disease and predict aortic dissection. And he actually underwent surgery and he's doing very well. He had that aorta replaced, and he went for a mechanical valve, and he's very happy. So abnormal flow in some small studies, in the left is a patient with nice straight flow coming out to the aorta. This is a patient with abnormal flow. In this study, they followed these patients up, and they showed that the ones with abnormal flow had higher growth rate. So it's definitely not been proven, but there's a suggestion that abnormal flow could be used to help predict aortic events. This is another study about a flow, and on the left is a normal patient, and this is a patient with a bicuspid valve, so 2 leaflets instead of 3, and you can see that the flow is haphazard even though the aortas are the same size. So again, there's a suggestion that flow could be something we should study more. believe it or not, there's only one study in the whole world where they've actually taken some aortic tissue from these areas of abnormal flow to see what is going on, and mapped it to the original scan. And this was published only 3 years ago. And what they showed was, in these areas where there's abnormal flow, the aorta is completely abnormal. So here you have these elastic fibres in the aorta which give it its flexibility. They just completely break down in these areas. So now we're really looking into whether we can use flow to predict these weak areas of aorta before it even happens. We know that certain scans can show hotspots in the aorta where wall stress is very high, and there's a possibility that this might predict aneurysm or rupture or dissection, but it's very experimental. And as I mentioned before, the shape of the aorta possibly could predict aortic events. So for some reason, longer aortas are at more risk of dissection, and in particular, certain shapes of aorta. We all have different shaped aortas, and this bovine aortic arch might have higher risk of dissection. And I'm just going to show you a graph here. So this is a normal aorta. So with a normal aorta, you have this innominous artery, which supplies one blood vessel to the head here and one to the right arm. But in a bovine arch, it has 3 vessels coming from this first vessel. So it supplies 2 vessels to the brain, and for some reason these patients have more dissections, and this certainly needs a lot more research. Are there any Americans in the crowd? Okay, so I can say that I really don't like this man, but there is one thing that he said which I felt really resonated with aortic dissection, and that is there are known knowns, there are things we know. We know there are known unknowns. That is to say, we know there are some things we do not know, but there are also unknown unknowns, the ones we don't know, we don't know. And as an aortic researcher, it's sometimes a bit disheartening to think we just know so little, but there is hope. And what we really need is big studies, which unfortunately are very expensive, where we follow up lots of patients like yourself and healthy ones over a long period of time and collect lots of data on them. Clinical data, scans, genetics, what their quality of life is like, and in particular biomechanical data, which hasn't really been, like I said, there's very few studies in the world. And that can help us really develop a prediction model. And I have to say, unfortunately, I believe this is probably 10 years away, something any good. At Imperial College, this is a study that I'm running, and one of my PhD students is trying to see if these hotspots on the scan actually mean anything. So we're doing scans on patients before their surgery. My student goes into theatre, he then takes the aorta with the consent of the patient. They don't need it anymore, or most of them wouldn't want it. And then we take that away and we do lots of testing. So we test the strength of it in different places. We look at it under a microscope, we do genetic testing on it, and then we go back to this scan and we see, do these hotspots actually mean anything? Because then you can actually validate this as a method of predicting aortic events. And it sounds very exciting, but it's only 60 patients. But if that proves to show anything, we want to try and get some funding to do a much bigger study. So in summary, predicting these events is important for you as individuals and for society. There's sadly no completely accurate way of predicting it, and because of that, population screening, you just can't justify it at the moment. But future studies may help, and it will allow individualized treatments, so that we don't just say, you've got a big aorta, let's replace it. We'll say, you have this risk of aortic dissection, do you want to have surgery? And just as a final comment, based on the research I've been doing, I believe that abnormal stress from these scans will mean in the future patients have early surgery, and if they demonstrate abnormal flow, then we might be saying to some of them, come back every couple of years so we can keep a closer eye on you. And through doing that, we may be able to reduce some of the acute aortic dissection slightly. Thank you very much.